Hello everyone and welcome to set 15 of the part 1 questions. Let's get started. First question here. A 60-year-old male, longtime patient of yours comes to your office complaining of sexual dysfunction. What is the differential diagnosis? What drugs are known for causing sexual dysfunction? So sexual dysfunction is non-specific and can be caused by a lot of different clinical conditions. Some of the questions you might want to consider when assessing a patient are things like decreased sex drive, are they having difficulty generating or maintaining an erection, are there any early morning erections as well. Now a few things to consider in your differential diagnosis. You want to think of hormonal disturbances, including maybe a low testosterone, maybe they have hyperprolactinemia. Then you also might want to think of things like depression. You might want to think of diabetes, which can be associated with a neuropathy and atherosclerosis, particularly the small vessel atherosclerosis that might lead to this. Also think of psychological or psychiatric etiology. Maybe there's some performance anxiety there. And then also think of medication adverse side effects. Now, which drugs are known for causing sexual dysfunction? So in general, certain antihypertensive drugs like the beta blockers, the neuroleptics can do it as well. Think of the SSRIs, antidepressants. Think of ethanol as well, which can also cause sexual dysfunction. Next question. What organisms are particularly known for causing infective endocarditis? So approximately 75% of cases are due to one of 4 types of organisms. About 30% of patients who get this are going to be due to Staph aureus. 20 to 30% are due to viridin streptococci, including strep mutans. 10% are enterococci, and then 5 to 10% are coag-negative staph, so things like Staph epidermidis. Now, when you know you have endocarditis, but nothing is growing on blood cultures, you're probably dealing with one of the Hassec organisms. So that's H-A-C-E-K, and that stands for Haemophilus, Actinobacillus, Cardiobacterium, Eikenella, and Kingella. Next question. Which type of lymphoma has a presentation that is very similar to CLL and fewer constitutional signs and symptoms? So this is a type of lymphoma that we call small lymphocytic lymphoma, which is one of the non-Hodgkin lymphomas. Now, lymphoma is a cancer of the lymphocytes within the lymph nodes primarily, and there are about 40 different types of lymphoma. We split them into Hodgkin lymphoma, which is actually just one type, and then we lump all the other 39 types into this category called non-Hodgkin lymphoma. But one of those 39 is called small lymphocytic lymphoma, which is considered to be basically the same type of disease as CLL, or that chronic lymphocytic leukemia. The only difference is that lymphoma is in the lymph nodes and leukemia is in the bone marrow and in the peripheral blood. Next question. A 44-year-old woman is seen in the ER for shortness of breath, malaise, and high fever. Chest x-ray reveals a right-sided consolidation, and her labs reveal a WBC count of 12,000. Which organism is overall the most common cause of lobar pneumonia? What organisms are the most common cause of interstitial or walking pneumonia? So this patient has what we call lobar pneumonia, and that's usually caused by strep pneumoniae. Now, classic pneumonia, and that's what we're talking about here, sometimes also referred to as typical pneumonia, is where you have pus and it's filling up that lobe of the lung, and that's why that chest x-ray looks densely whited out, and you have fever, productive cough, the patient looks really, really sick. Remember, this is considered typical. Strep pneumo is the most common one. Other things that can cause it, think of Staph aureus, think of H. influenza, even Klebsiella. Lots of bacteria can do this, but think of strep pneumo as being the most common. So let's talk about atypical pneumonia, and this is a term that we should probably be phasing out. You still see it, especially on the boards as well. Atypical pneumonia is usually meant when a patient has a milder illness. They have some cough, they have some mild fever, but they aren't super sick. They're still walking around. That's why we call it walking pneumonia. Now that x-ray, instead of that dense consolidated lobar pneumonia, things are really concentrated in one area, these patients are going to have sort of this patchy, sort of this interstitial infiltrate that's kind of going all over the place. Sometimes we're referred to as interstitial pneumonia. Now if you hear interstitial pneumonia or walking pneumonia or even atypical pneumonia, you want to think of 3 bacteria. You want to think of Mycoplasma pneumoniae, Chlamydophila pneumoniae, which is formerly called Chlamydia pneumoniae, and then Legionella pneumophilia, and that's going to cause Legionnaire's disease as well. And then the other thing to think of when you see sort of maybe a patchy looking infiltrate, you want to also think of viral pneumonias, and that can be from RSV, adenovirus, or even influenza. That can give you that interstitial pattern as well. All right, next question. What is the difference between a promoter region and an enhancer region? Well, a promoter region is a site on the DNA where RNA polymerase and other transcription factors bind just upstream from the gene locus itself. This is your TATA box or your TATA box or the CAAT box. So when RNA polymerase binds to these promoter regions, it promotes gene expression and transcription. It's kind of like a place for the RNA polymerase and transcription factor to latch onto to get started. And then an enhancer region is a similar, it's a sequence of DNA that enhances gene expression by binding transcription factors, but it doesn't have to be upstream from that actual gene. It can be upstream, downstream, nearby, very far away, and it can even be within an intron of the gene itself. All right, next question. A 30-year-old man is at an inpatient facility for opioid addiction. What symptoms might this patient experience while discontinuing opioids? So patients are going to get things like tremor, chills, muscle and bone pain, perspiration, so a lot of sweating. They're going to have flu-like symptoms. They're going to yawn a lot, which is very interesting. If you have someone who's just yawning up a storm, you want to think, hey, have you been taking a lot of opioids? Vomiting, diarrhea, and the restless leg syndrome. So people are very, very jittery. They feel uncomfortable. Next question. What are the signs of right-sided heart failure? What are the signs of left-sided heart failure? And what is the most often cause of right-sided heart failure? So this is a long question as well. So if the right ventricle fails, it can't push blood forward into the pulmonary artery. So where does that blood go? Well, it backs up into the IVC, into the SVC. So signs of right-sided heart failure would include JVD and peripheral edema, and maybe even hepatic congestion as well. So now what are those signs of that left-sided heart failure? So in the left-sided heart failure, if the left ventricle can't push blood forward into the aorta, where does that blood go? It backs up into the pulmonary vein and the lungs. So you get pulmonary edema, especially when lying down. So that's the orthopnea, that you get dyspnea on exertion, and then paroxysmal nocturnal dyspnea as well, or PND. So most of the pulmonary symptoms of CHF are from left-sided heart failure. And then, what is the most often cause of right-sided heart failure? Well, you'll hear this again and again. The most common cause of right-sided heart failure is left-sided heart failure, because once that blood backs up from the left ventricle into the pulmonary vasculature, now the right ventricle has to push blood against all that extra pressure as well. And the right ventricle is weak and wimpy when compared to the left ventricle, right? So the right-sided pressures are normally lower than the left-sided pressures. So when that pulmonary pressure goes up, that right ventricle is going to fall down in a hurry. So the most common cause of that right heart failure is left-sided heart failure. So when dealing with right-sided versus left-sided heart failure, I want you to remember the following. Right-sided heart failure will often result in systemic problems, JVD, edema, whereas left-sided heart failure will result in pulmonary problems, pulmonary edema, pulmonary hypertension, that type of stuff. All right, moving on to the next question. What medications are considered first line in the treatment of ADHD? So we use probably far and away more stimulants than anything else. So that's methylphenidate, that's going to be dextroamphetamine. But then we have a new one called atomoxetine, and that's a selective norepinephrine reuptake inhibitor, a much slower medication. Sometimes if you have patients who have a lot of insomnia, sometimes I have seen some patients use clonidine as well to help with their symptoms. Next. How many umbilical vessels are there? Which umbilical vessel has the highest oxygen content? So first we have how many vessels are, well there's 3. You have 2 umbilical arteries and 1 umbilical vein. Now which umbilical vessel has the highest oxygen content? That's going to be the umbilical vein. So in the infant, the umbilical vein, the ductus venosus, and the pulmonary artery all have higher oxygenation than the actual aorta. Next. What abnormal lab values would lead you to suspect alcoholic hepatitis? So remember, you're going to see an AST greater than ALT, and usually that's a greater than 2-to-1 ratio. An easy way to remember this is the mnemonic A Scotch and tonic for AST. So that's alcohol inducing that elevated in LFT. All right, guys, so that's the end of our question set number 15. I hope you learned something. I'll see you next time.